Hello, everyone, and welcome to our webinar titled CAQH CORE Value-based Payment Initiative, Industry Developing Practical Solutions. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach here at CAQH CORE. Next slide. I'd like to mention a few logistical items. You'll receive the slides on Monday, and the slides and recording will also be on the website starting next week. Also, we'll save time at the end of the webinar for your questions, so feel free to go to the questions panel on the right side of your screen and add your questions at any time during the webinar. Next slide. I'd like to thank our guest speaker, Troy Smith, Vice President with Blue Cross Blue Shield, North Carolina. Troy, thank you so much for being here today. Next slide. These are the items that we will be discussing today during our webinar: an overview of our VBP initiative, the outcomes of our advisory group work on value-based payments. Then we'll talk a little bit more about our work on patient-provider attribution. And then we'll end the webinar with what you can do to engage with our efforts, followed by time for Q&A. Next slide. And now I'd like to introduce our first speaker, CAQH CORE Director, Erin Weber. Erin?
Thanks, Jessica, and thank you, everyone, for joining us on a Friday afternoon. I'm going to give a little background for you on the CORE Value-based Payment Initiative, and I'm going to start off with a little history around why CAQH CORE was started initially. Back when HIPAA was first passed, it included some requirements for electronic transactions for the administrative transactions in healthcare. So when you think about billing, eligibility, claims, all of this had been previously done via paper, and the industry was moving towards electronic exchange of information. As the plans and providers began using these electronic transactions, it was discovered that many organizations were still using them slightly differently, which made it very difficult to automate the exchange of information, particularly from a provider perspective who was working with multiple health plans. Each health plan had slightly different requirements, making it hard to create automated solutions. So the industry came together through CAQH CORE to develop what are called operating rules to support some of these administrative transactions in healthcare. The operating rules put requirements around some of the transactions related to expectations for system availability and response time and certain data content within the transaction itself. Today, CORE represents nearly 75% of the insured U.S. population, and our participating organizations include health plans, providers, vendors, government entities, associations, standard-setting organizations. It's a really a strong blend of different stakeholders coming together to work on solutions that can help accelerate the automation and interoperability of the administrative side of healthcare. CAQH CORE was designated by the Secretary of HHS back in 2012 as the National Operating Rule author, and several sets of the CORE operating rules are federally mandated through HIPAA at this point. We are governed by a multi-stakeholder board with equal parts providers and health plans, so nothing moves forward within CAQH CORE unless those two key stakeholder groups agree, which can be challenging at times. On the next slide, I'm going to talk a little bit about what operating rules are. And the Affordable Care Act defines operating rules as the necessary business rules and guidelines for the electronic exchange of information that are not defined by a standard or its implementation specifications as adopted. Operating rules are very common in other industries, such as financial services, telecommunications, transportation. But when we think about operating rules in healthcare, they don't necessarily specify whether or how a payer or provider structures a business process supported by an electronic transaction. So, for example, today we're going to talk about patient attribution. Operating rules would not specify the methodology behind the attribution, but they could specify rules around how that attribution information is exchanged between a health plan and a provider. On the next slide, just a little background on how core operating rules are developed. Initially, we develop operating rules through a lot of research. So CORE conducts environmental scans, industry surveys. We actually have an industry survey out right now that you may have seen related to the exchange of medical documentation. And we use that information to develop a list of potential rule opportunities. Then those opportunities are reviewed by the CORE participants through various work groups that actually then select an opportunity and develop requirements related to that opportunity for operating rules. We also use pilots and ROI to support more quick and broader market adoption. Once a rule has been drafted, it then goes through a formal voting process with CAQH CORE. Each level of the process includes quorum and approval level requirements all the way up through the CORE board. That ensures we have the necessary support for broader implementation of an operating rule. Then if the CAQH board determines it's appropriate, operating rules can be considered through HIPAA for federal mandate. That process involves CAQH CORE, the board first writing a letter to NCBHS describing the value of the operating rules and the impact they could have on the industry. NCBHS is the National Committee on Vital and Health Statistics. They are an advisory body to the Secretary at HHS on administrative simplification and other issues within healthcare. Depending on NCBHS, NCBHS will hold a hearing, hear from the industry about the potential requirements, and then make a recommendation to the Secretary at HHS on whether the operating rules should be mandated. Then, should HHS decide to mandate the rules, they will draft an interim final rule, and the industry will have a 60-day comment period to provide feedback on the rule, and then HHS may adopt the final rule. When you think about that timeline, HHS, once they mandate an operating rule, the industry is given 25 months to implement and adopt the new rules. So from the time of initial rule development to a potential mandate, there's as long as 3 years for the industry to prepare for operating rule implementation. On slide 9, over the past 10 years or so, CAQH CORE has developed a number of operating rules primarily focused on the fee-for-service healthcare environment and the typical revenue cycles, functions, and workflows that are needed for healthcare billing and payment. You can see here some examples of where operating rules are currently being used and where operating rules are currently being developed. Our most recent set of operating rules address the prior authorization transaction and is really focused on enabling greater automation of that exchange between health plans and providers. And I encourage you to attend our town hall webinar next week to hear more on that initiative specifically. As I mentioned, when CORE was first founded back in 2000s, the market was primarily focused on the exchange of information for fee-for-service billing. But as we've seen on slide 10, the industry is really now shifting from fee-for-service to a more value-based environment. I probably don't need to tell those of you who signed up for a value-based care webinar that value-based care is a growing component of our healthcare environment now. It's becoming increasingly common. Most recently, 60% of healthcare dollars are linked to some value of care delivered. We're starting to see some impact of these value-based arrangements. I have recent information coming out of Change Healthcare saw that value-based models are accruing cost savings of about 5.6% with equal or better care results. But there's still challenges. 57% of providers recently said that they don't necessarily feel like they have the data and the tools to be successful under value-based care. Coming out of that challenge, a couple years ago, the CAQH CORE board really came together and identified that they were at their organizations, both the plans and providers were encountering many of the same challenges they initially were encountering when CORE was first founded. There are a wide range of value-based payment models out there right now, and everyone is doing it slightly differently. There are different data needs, different expectations for when that information is shared, and that's adding some administrative challenges to the value-based care environment. The CORE board determined that this should be a priority area for CAQH CORE, and given our experience in developing industry solutions, something that the CORE participating organizations should take head on. So out of that sort of charge from the board, CAQH CORE spent about 18 months researching and interviewing industry executives about the challenges they were having at their organizations, and published a white paper last year identifying really 5 key opportunity areas where the industry could streamline the implementation of value-based payments and really prevent some of the roadblocks that we saw in the early days of HIPAA from becoming more prominent or entrenched in the value-based payment arena. The first of those opportunity areas is data quality and uniformity. So standardized identifiers, data elements, transactions, and code sets, setting some expectations for the information that is needed across the industry. The second area that came up in the research was interoperability, not just technical interoperability, but also process interoperability, thinking about the processes and ways information is shared and creating some common expectations across the industry. The next topic that came up in the research consistently was patient risk stratification and the need to promote collaboration and transparency of risk stratification models, and also the sharing of information around patient risks between plans and providers. The next topic that came up, and this is a topic that I think there are many organizations working hard to address now, is quality measurement. While quality in itself is a clinical challenge, the measurement and the sharing of quality measurement information is an administrative burden, and we continue to hear from the provider community that this is a challenge, and it was not something we could exclude from the report. And finally, where we'll focus today, the 5th challenge we heard about was patient-provider attribution. Improving provider awareness of patient attribution and the transparency in the underlying attribution models was a frequent theme in the research. I encourage you to go to our website, pull up this report where you can read more about these opportunity areas in detail. But our vision and our goal is to create a common infrastructure that drives the adoption of value-based payment models by reducing the administrative burden and improving transparencies across the clinical and administrative verticals, really making sure organizations have the right information at the right place at the right time, and having some industry expectations around that. As we did this work, it was important to recognize that the industry is not yet coalesced around a single model for value-based payment. We certainly know there are a lot of different ways that value is being measured and paid for in healthcare, all the way from bundled payments to global payments. And we thought about that as we came up with these 5 opportunity areas to ensure that any operating rules or solutions that the CAQH CORE participants might pursue would be applicable across these various models. Once the research wrapped up and the white paper was published, CAQH CORE formed a value-based payment advisory group in early 2019. So the group launched earlier this year. The advisory group was composed of key industry executives and thought leaders in the value-based payment space. That group met for about 6 months and reviewed a list of 19 more detailed opportunity areas. You saw the 5 overarching. Our research really kind of could be more clearly defined into 19 clear opportunity areas to prioritize for potential operating rule development. It was a diverse group of stakeholders. We had plans, providers, vendors, and other thought leaders in this space convening to help make these prioritizations real. One of our value-based payment advisory group members was Troy Smith, Vice President of Healthcare Strategy and Payment Transformation at Blue Cross Blue Shield of North Carolina. We are also fortunate to have Troy as a member of the CAQH CORE board, and he has also generously volunteered to share some of the experience of the advisory group and talk through some of those opportunity areas that I mentioned before. Before I turn it over to Troy, I'm going to turn it to Jessica for a polling question. Jessica?
Thank you, Erin. So let's take a quick moment and hear from our audience. Let's go ahead and launch the poll. We'd like to know what percentage of your business falls under a value-based payment structure. Is it small percent, 0 to 25%, 25 to 50, et cetera, or if you don't know or it's not appropriate for your organization, go ahead and don't respond or say MA. Let's give this just a few more seconds, get a little bit more of the audience involved, and then we'll share the response. Let's go ahead and do that. So I'd love to hear Erin's perspective on this, but I thought it was really interesting that it's mostly a small percent or not appropriate. Is that what you expected, Erin?
Yeah, I know that we have a mix of stakeholders registered for this call, and you know, I think what this shows is that while value-based payments are touching most organizations at this point, it's not necessarily a huge component of their revenue. But I wonder if we had asked the question differently, what's the increase year over year, we might see a trend there.
Thanks, Erin. And now for our next segment, I'd like to introduce Troy Smith. Troy, thank you so much for joining us today.
Thank you, Jessica. Can we head to the next slide here? As we ramp this up, a lot of what we've been doing at our plan has been focusing on value-based transformation. And what really energizes me as we look at what we're doing with CAQH here is how this can help more broadly across the industry. So we started the advisory group earlier in the year in 2019, taking a look at the typical fee-for-service workflow. You can see here with the gears, when you're looking at how the patient encounter is scheduled, when the encounter occurs, claim submission, all the way through payment. And as we were looking at this, we were like, where are the opportunities really to drive standardization? And so at the beginning of the revenue cycle, when the patient schedules an appointment with the provider typically runs an eligibility check to make sure that the plan benefit exists and that the requested service and the patient is eligible for treatment. And so for us, when we're looking at that, we're like, is it enough to just really know that the patient is covered, or is it also important to know whether the patient's attributed to a particular provider, primary care physician or specialist, or to better understand what gaps in care may exist for that particular patient so that the providers that are covering service for that member know what exists or what opportunities may lie there. So we're not going to go through every single one of these use cases, but as you see further down the line, there are limitations to using the fee-for-service payment model when dealing with value-based payment. The healthcare claim does work really good for a fee-for-service environment, but as you start moving from fee-for-service to fee-for-value and then into other value-based models, there's other opportunities that we want to consider. The provider states that they conducted X service and therefore should be paid Y amount. VBP models require more information than just the services provided. We're looking at quality, we're looking at outcomes, we're looking at experience. So as we're looking at these things and how can we standardize them, we saw this as a key gap to be identified by our group. And it represented an opportunity to potentially standardize the additional data and content and method of transfer and non-clinical related service information. Next slide, please. So when we started talking in February and talking about this fee-for-service revenue lifecycle, seen on the previous slide with the gears, the corresponding pain points at each step in the workflow for the participants was highlighted. And so you can see on this table on this slide some of the challenges that we were looking at. Our group looked to serve as an industry collaboration to guide the development of common approaches for the exchange of data and to reduce administrative burden and improve the patient experience of care. We reviewed a list of 19 opportunity areas and looking at all these different pain points and what did we think would provide the most benefit. These opportunities were condensed into 15 subsequent opportunities. And then after extensive discussion, we rated their support on a Likert scale, and then we came up with what our priorities were for rule development. This resulted in the 5 opportunity areas chosen for further action. And as you can see on this table here, many of them relate to attribution, risk stratification, financial responsibility. Next slide, please. So on slide 20 here, we see the high-level recommendations that emerged from the advisory group. 2 opportunity areas resulting in pain points related to attribution, as I mentioned, and risk identification. And we wanted to move those into an operating rule development group through our value-based payment sub-team. This is the most common rule development method as we try to standardize our practices. One opportunity area related to the inclusion of expanded code sets on claims to better exchange non-service related clinical information, and is recommended for an operating rule development through a pilot program that had already had a narrow scope. These remaining 2 opportunity areas that we're looking at related to the notification of the need for additional documentation and standardization of the exchange of additional documentation. They aligned with existing core efforts and including the CAQH CORE initiative on the electronic exchange of clinical documentation, for example. Next slide. So let's take a deeper dive in starting how we started our 2 opportunity areas that will be continued in pursuit with our value-based payment subgroup. With patient-provider attribution status, a major challenge for providers is that they're often unaware of a patient's attribution status within their VBP contracts at the point of service. So this can result in care gaps, shortfalls in reporting, lost opportunities for coordination of care until after the patient visit has occurred. Our advisory group believed that there's an opportunity to electronically share this attribution information at the time of the patient eligibility check. This would allow the provider to gain greater access and picture of patients' health, resources available to them through their value-based contract, as well as further knowing who their patient's attributed to, if not the requesting provider, who is responsible for their care and therefore provide greater care coordination. In addition, we have the challenge of patient risk identification. Providers and health plans may be unaware of patient health status or risk factors that can impact care, cost sharing, or data reporting requirements. For example, if a health plan, according to a health plan, a certain patient is a smoker, and therefore the provider must walk through a smoking cessation program and other options in order to meet their quality measure benchmark. If this patient had paid for a smoking cessation program out of pocket and quit 6 months ago, there's no electronic format for a provider to understand or to have that information shared with the provider back to the health plan. An opportunity area here is for stakeholders to agree on standardized data elements, documentation format, timing, and exchange mechanisms for bidirectional health plan and provider communication concerning risk factors at the point of service when they can be most actionable. CAQH CORE staff has continued to research these opportunity areas to further support operating rule development. And since the subject matter experts on these 2 topics differ within an organization, the first subgroup will launch October 16th, and then tackle provider-patient attribution as its first focus area. Next slide, please. The third-ranked opportunity area looked to address challenges associated with care gaps, quality measures, and/or performance metrics. As we described earlier on the call, a healthcare claim is a great mechanism for a provider to tell a health plan what services were provided, but it's not the best way to share what outcomes of that service were. The expanded use of code sets, such as CPT2 codes, which included coded value for things like blood pressure, reading to performance measure exclusion modifiers, could fulfill a vast majority of reporting requirements and minimize the burden of year-end reporting. And CORE is looking to launch a pilot program to test the value of this opportunity area within the industry and measure the impact on provider reporting burden. Next slide, please. On slide 23, we have our fourth opportunity, which addresses notifying a provider of the need for additional information and/or documentation. Beyond documentation to adjudicate a healthcare claim, health plans often use additional documentation to determine whether care gaps have been filled and quality performance metrics have been met. When that documentation is not sent with the healthcare claim, providers often wait until the end of a reporting year to submit all documentation related to all patients at once. Our group agreed that the opportunity area here would be to let providers know exactly what documentation or information was necessary at the time of claim submission in order to satisfy their value-based payment contracts. This could be done by stakeholders agreeing upon standardized data elements, documentation format, etc., for health plans to notify providers. The important thing is conducting this notification in an electronic format that works within the existing provider workflow, which will be the least disruptive to their patient care activities. CAQH CORE is currently working on a pilot program to test methods of electronic notification for the need for additional documentation to satisfy a request for prior authorization. The learnings from this pilot will help scope infrastructure necessary to apply best practices to value-based payments overall use case. Next slide, please. Finally, on slide 24 here, we have the opportunity area to address the exchange of additional documentation. Pervasive in all aspects of healthcare is the lack of standard format and mechanism to electronically exchange additional documentation. Value-based payments are no different, as additional documentation must be exchanged to close care gaps, share quality and performance metrics, etc. However, the wide variety and continued use of non-electronic methods such as fax and mail may delay provider submissions and subsequent adjudication of information. The advisory group saw an opportunity for stakeholders to agree upon standardized data elements, format, timing, exchange mechanisms, and other details for the sharing of additional documentation. As the HHS designated operating rule authority mentioned, CAQH CORE is required to create operating rules to help standardize the exchange of additional documentation or healthcare attachments. CAQH CORE launched an attachments advisory group last week and to begin the rule development process and scope opportunity areas to enhance the exchange of electronic attachments. As part of their charge, this group will look at the use cases that include prior auth, healthcare claims, and value-based payments. All that in mind, I'll pass this back to Jessica to take us to our next polling question.
Thank you so much, Troy. This segment was originally going to be shared with another guest speaker, Steve Rosenthal from Montefiore, who couldn't be with us today. So I really want to thank you, Troy, for covering your portion of the presentation as well as his. So for the next slide, we're going to take another polling question from our audience. We would like you to engage with us in our efforts. So please let us know if you're interested, or if you're unsure if you're interested. We'll also send you some more information, because our work is only as strong as how many people collaborate with us. So let's keep this open for a few minutes, and we won't share the results of this poll since this is mainly internal. But thank you so much for those of you who want to get involved or who need more information. And with that, we'll go to our next segment of the webinar. I'd like to introduce our next speaker, Lena Gebremarian, who is manager here at CAQH CORE. Lena?
Thanks, Jessica. So next slide, please. So now we're going to talk a little bit more about patient-provider attribution, which was our top opportunity area from the VBP advisory group, and will now be the subject of discussion for a VBP subgroup, which is posed to launch on October 16th. As a reminder and level set for folks, attribution matches individual patients in a population with providers, which then ultimately determines the patients for which a provider, either as an individual or as a group, is responsible. This forms the basis of analysis for metrics underpinning VBP, such as total cost of care and quality measures. Providers need to know which patients are in their population so they can understand the reporting requirements and better understand who else may be involved in this patient's care. Health plans often send providers attribution information on a regular basis, either quarterly or monthly. But these are often bulky files that must be downloaded from the payer site and then integrated with the provider system, which can be a time-consuming endeavor and increase administrative burden. Furthermore, a list of patients attributed to providers still leaves several unanswered questions that are critical to provider success under a VBP model. First question, why is this patient in my population? VBP contracts between health plans and providers often include information on the methodology for assigning patients to a population, but the clinicians actually providing the care often don't have insight into those contracts and may not know why a patient is in their population, especially if it's a patient who they've had no prior relationship with. Second question, who's on first? Patients may be attributed to a single provider or a group of providers, which can leave ambiguity as to who is the primary care provider ultimately responsible for the patient. Furthermore, patients with chronic conditions such as heart disease or diabetes may have a specialist who acts as their PCP, which may or may not be reflected in the attribution model. This ambiguity can lead to care gaps or duplicative efforts, which adds to waste in the healthcare system. Third question, who else is involved? In some VBP models, providers are penalized when patients in their population visit other providers. Providers may not have insight as to where their patient is seeking care. Preventing this leakage is a large incentive in VBP contracts, but without visibility into patient utilization, providers can be unaware when this occurs until after the contract period has ended. So you can start to see how the answers to each of these questions is critical to well-coordinated, high-value patient care. So say there's a John Doe who's a diabetic who has been using his specialist as a PCP for several years, but John is now attributed to a PCP for a value-based contract. This PCP might not know that John has a history of diabetes and takes an active role in his care. The PCP's care management team can spend time trying to get John to schedule an appointment. Meanwhile, John is receiving great medical care from his specialist, but since the specialist is out of the VBP network, the PCP can be penalized. Success under VBP requires knowing the answers to all of these questions. But before a provider can even begin asking these questions, they need to ask one very important question. Is this patient attributed to my population? Next slide, please. Prior to the point of service, providers often don't know whether a patient is attributed to their population. As previously mentioned, providers may receive regular reports on who is in their population, but these are delivered in various formats with varying degrees of information. Additionally, since these lists are delivered in the aggregate, providers often don't have time to deviate from their pre-appointment workflow to log into different systems and look up to see if a patient with a scheduled visit is attributed to them. Just as with fee-for-service, CAQH CORE will work with current standards to create uniform data content when sharing the attribution information, define the exchange method and format, and set requirements for when this information must be shared. The VBP subgroup, reminder, launching October 16th, please sign up, will discuss potential operating rules that relate to data content, infrastructure, and connectivity around this business process. Data content operating rules may define the data elements, which must be shared when requesting and sending provider attribution methods. Infrastructure operating rules could specify an ideal timeframe to communicate the attribution status. And finally, connectivity operating rules would define the exchange method and format, which can be used when exchanging this information. Next slide, please. So here we have an example of how a data content operating rule would work. Requesting attribution status prior to the point of service would require provider and patient identifying information for health plans to be able to link a patient to a provider's population in their VBP contract. So a data content operating rule would specify what data elements a provider would need to send in order for a health plan to be able to return a valid response. This response could include information such as the attribution status, yes or no, this patient is attributed to the requesting provider, who the actual attributing provider is if it's not the requester, and pertinent information such as patient care gaps or requirements for coordination efforts. This request and response could pertain to a singular provider requesting information for a singular patient, or a group of providers requesting information for a group of patients, or any combination. Infrastructure and connectivity rules will provide consistency in how that information is exchanged. Moving on to slide 30. Infrastructure and connectivity operating rules will set industry expectations for communicating patient-provider attribution status. Infrastructure operating rules would increase the reliability of attribution information by defining how often this information should be exchanged, the time frame for acknowledgement of a receipt of an attribution request, and a time frame for a final attribution status response. A connectivity safe harbor would define exchange methods and formats that should be used when exchanging attribution information. This would eliminate bulky Excel files and FTP sites in favor of truly electronic exchanges via REST or SOAP, using consistent standards such as XML or FHIR. Infrastructure and connectivity operating rules would work across use cases, and an update to the core connectivity operating rule is planned for 2020. So with that, I'll hand it back over to Erin Weber, CAQH CORE Director, for more information on how we can get involved in this effort.
Thanks, Lena, and thanks, Troy, for sharing some great information about our future work in value-based payments. I'm going to talk a little bit now about how to get involved. Earlier in this presentation, I noted that the operating rules are developed by the core participating organizations. Any healthcare organization can join and participate in CORE, and if you are not already a participant, I encourage you to become one. There are lots of advantages of joining, the first of which is that you can collaborate with your colleagues from around the industry to develop requirements that will help automate the exchange of information in healthcare, and in particular participate in the initiative that Lena just outlined related to patient attribution. You can represent your organization. Each organization has a vote on where the rules are headed, influence the direction of policy, and engage with decision makers that comprise about 75% of the industry. On slide 33, this is just a selection of the various types of stakeholders that are currently engaged with CAQH CORE. We do have the full list of organizations on our website. CORE work groups are chaired by core participating organizations, and it's a really great opportunity to help drive the direction of health information exchange. In particular, for this group, we are looking for subject matter experts in provider attribution and those familiar with the HIPAA mandated transactions. As with any core subgroup or work group, anyone from a core participating organization can participate in the group. Organizations just get one vote. If you are already at a core participating organization and have been engaged with us for some time, you will know that value-based payments, and in particular patient attribution, is a new area for us. And so we encourage you to reach out to your colleagues working in that space, talk to them about the work that we do and the role that they can help play with this subgroup. From a commitment perspective, we anticipate this group will meet monthly for 1.5-hour conference calls to help vet and work on the potential operating rule requirements. In between calls, we do conduct straw polls and ballots to get a better sense of support for the direction of the operating rules. And from a timeline perspective, as Lena mentioned, this group is launching on October 16th with an introductory call, and then we'll meet throughout the first half of 2020 to develop operating rule requirements. At that point, assuming a draft rule or rule set is created, then it will go through that formal balloting process that I mentioned earlier in the call. This is a really great opportunity for the industry and for your organization. We are happy to talk with you directly about core participation and what that might mean for your organization if this is something of interest. You can always reach out to us at core@caqh.org. I think that email address is actually on the next slide. Oh, actually, first we're going to do a polling question. So I'll turn it back over to Jessica.
Thank you, Erin. So we'd like to know from you if you're interested in engaging with us in this work. So let's go ahead and launch that poll and give the audience a few minutes to mark their interest. And if you're unsure, we'll just send you some information so you can make a determination. Okay, so we've heard from a majority of the group, so let's go ahead and close this. I don't think we'll share it since this is internal, but for those of you, again, who said yes or unsure, we will be reaching out to you. And now we do have some time to take your questions. Feel free to add your questions to the questions panel. In the meantime, let's get started. So the first question is for Erin or for Lena. So the question is, what transactions does CAQH CORE anticipate using to report VBP data, for example, the eligibility transaction?
That's a great question. And that's really going to be up to the subgroup participants and the core participants. Lena laid out some of the opportunities for what information and when that information could be exchanged. The mechanism for doing so could be an eligibility transaction. It could be an enrollment transaction, potentially. And the subgroup will actually do the work of evaluating what's the most appropriate mechanism to exchange that information.
Thank you, Erin. The next question is for Troy. Troy, the question is, how can EHRs better support the streamlining of billing processes for new value-based care payment models?
I think some of the key things that we could look at there are bidirectional information sharing. So that's where the claims and clinical information are going back and forth between payer and provider. I think being able to really have a clear view of who the provider to patient link is through that attribution information. And really, as we're looking at some of the things around outcomes and quality, being able to push that back to a payer from a provider's EHR would be beneficial. A lot of what the metrics that we have in place today focus on claims-based models, and I think being able to have that extra dimension of clinical information or insight to be able to tie that into like how well things are actually going from an outcome perspective will help enhance what the VBP payment set looks like.
Thank you, Troy. That's really helpful. So the next question I'm going to send to Lena. What is meant by attribution status?
So when we talk about attribution status, we know that attribution means matching a patient to a provider for the purpose of their population health, and the provider is then responsible for that patient. When we talk about attribution status, we just mean the answer to the question, is this patient assigned to a provider's population? So yes, no, maybe are pretty much the attribution status options that we have.
Thank you, Lena. I think the next question is back to Erin. Does CORE think quality reporting data would be included in the electronic claim transaction?
That's another good question, and my answer is similar to the prior question that came my way. I think our research revealed that there may be opportunity to share that information via claim transaction or an attachment to that transaction, but it's going to be up to the core participants and the subgroup to do the heavy lifting in terms of evaluating what's most appropriate for that information to be shared.
Thank you, Erin. For the next question, I'm going to send that back to you, Troy. The question is, how do you measure the actual savings attributed to the value-based payment initiative?
So this one, at least at our particular plan, is that we're setting our total cost of care targets based on a medical expense trend. And so as we're aligning those members to their doctors and summing up the claims for the system or the ACO, and trending that forward a bit from the medical expense perspective, That really, just like many others, we're looking at like what the deviation from total cost of care is, if we're really seeing it in the claims experience, and then our actuaries are putting that into pricing the next year. So for us, it's not necessarily like a unit price reduction where you can see it that year and put it into premium. Where we have to play a little bit of a waiting game and have that bake into the trend so that we can put it into the next year's premium.
Thank you so much, Troy. The next question is for Aaron. The question is, payers are denying claims until receipt of medical records. How can we address this to avoid significant payment delays?
You know, one of the things I'd highlight here, and I mentioned that we're having a town hall webinar next week on the 10th, is that there's a lot of work being done in the industry to streamline and move the exchange of medical records or other documentation needed for a claim to an electronic process. And we, in fact, have an advisory group that just launched this month to look at requirements to create some uniformity in the industry and how that information is exchanged. And so I think that you know, certainly we hear that that's a challenge, and there is work being done on that. So if you're interested, I would attend that webinar to hear some detail on the progress of our work on attachments.
Thank you so much, Aaron. And the next question may have a similar answer, but I will ask you anyway. Are prior authorization and rejection codes and their meanings readily available to all providers?
Even though we haven't talked about prior authorization in this webinar, we actually have a brand new phase of operating rules that specify the data content for prior authorization transactions, which basically specifies that health plans, when pending a prior authorization request, should respond with rejection codes and their descriptions as to why the prior authorization has been pended or denied or canceled. So that information is available on our website, and you can also take a look at the X12 PR3 implementation guide for more definitions and descriptions.
Thank you so much, Lena. The next question is for Aaron. Aaron, someone's asking if dental will be included in the VBP initiative.
Yeah, and I've noticed I've gotten a couple of questions related to dental, and I would encourage dental organizations to participate in the work that we are doing. Certainly there are some nuances to that particular part of the industry that are important to take into account during operating rule development. And so I would encourage the dental organizations to join the process, and where your needs may be the same or different from the medical industry, I think it's important to specify those during the process.
Thank you so much, Aaron. So we don't have any more questions, so let's go ahead to the next slide. And I just want to offer to you that if you do have questions afterwards, you can reach out to us and ask them via email. So on this next slide, you'll see some of the free resources that we have available on our website. I'd like to particularly mention in the lower right-hand side our PA white paper that was just released. And also, if you're interested in any of our past webinars, I saw that there were a few Medicaid questions that came in. We did do a Medicaid VBP webinar a few months ago. Please feel free to access that recording, and you can learn about what states are doing in value-based payments, but also all of our webinar content is available online free of charge. So it's a great resource for all of you. Let's go on to the next slide. These are the next few webinars we have coming on in October, and we also have a webinar on November 5th on EFT-ERA and our phase 3 efforts. We're going to do that webinar with X12, so we'll be posting that information and sending it out shortly. Let's go to the next slide. And with that, here's our email if you'd like to reach out to us, and we thank you so much for joining us today. Have a great afternoon.